I promise to go quickly. So the nice thing about going last is that we can just be very, very vague and very, very macro. And so I'm just going to talk about the range of opportunities that we have in this field to improve what we currently do. So I put this together just to kind of outline what it feels like for someone who goes, who starts to, experience some symptoms and the kind of path that they usually experience before recovering. So they start up here at the top left, they feel bad, they're not really sure why. They probably don't talk about it because they're confused, they don't really have the vocabulary or the framework to understand what they're going through. There's a lot of stigma involved, people probably don't talk openly about this, at least we've seen it definitely in other fields. I know from my time in grad school, people talk pretty openly about it, but I don't think that is the case outside of there. Fingers crossed, they seek treatment. We know data from the World Health Organization suggests that they, statistically probably don't, but if they do, and they have some extraordinary fortune in the United States, and then they might see a provider and they might get diagnosed accurately. At that point, again from the World Health Organization, consistently across the world, about 30% of those people we never see again. They get that diagnosis, but they don't get any kind of, or they don't follow up for any kind of care. The rest of them, move forward. Provider gives them a treatment. From STAR-D, we know that about 30% of those people will recover with whatever they try first. 70%, will not recover. They then go and they try something else. That has about a 25% chance of working. They reload and they try the third time. Now there's about a 20% chance that they'll recover. There's a couple of people left at the end of this who did eventually recover, and about a year later, 40% of those people who did recover will eventually have relapsed. It's pretty bleak, but I think that the counterpoint to that is that psychiatry is a field of huge opportunity. I think that when you think about the overall framework that individual will have just gone through, and you start to segment different aspects of the treatment or the care pathway, and there are things that we can do all the way along, right? We can start and we can think about ways that we can do a better job of detecting these problems sooner, thinking about frameworks that we can get a more accurate diagnosis or an earlier diagnosis, and a lot of the work that's been done around there is more about efficient screening. Things like the PHQ-9 are very helpful there. We can think more, carefully about access to treatment, what options are available. Srijan just talked about there. Things like web CBT, things about different access models, and ways that we can just improve the uptake of treatment regardless of what kind of treatment that is. When people do come in, and something I'm just going to highlight in a moment, suggests that there may be an opportunity in the treatment selection process to also improve things. At the moment, it's sort of a trial and error. It's not really trial and error because we've kind of converged on stuff that we know generally works, but there's certainly potential for improving those decisions at an individual person level. Fourth, and something that has definitely been emphasized at this conference, is the way that we actually track performance, moving away from a world where we're flying blind, we throw a prescription out, the person comes back 6 months later and we ask them whether or not it worked. I think that there are a range of opportunities and different approaches that we can take to track performance during treatment, whether that is in some kind of passive, mobile phone-based way, or whether that is just by administering questionnaires and other things that we know do seem to correlate with outcomes. And then finally, I touched on it just at the end of that journey, but a lot of people do, eventually relapse. That we still could do a lot better in identifying who might relapse, what we can do to kind of prevent that relapse, whether we can increase the persistence of recovery afterwards. And so I'm going to spend, max 5 minutes just highlighting some work that I have seen that I really liked. Some of it we did, some of it we didn't do, but I just want to kind of give a moment to just give you kind of an overview of all of the ways that forecasting is being done right now in ways that I think go beyond proof of concept. In general, one thing that you'll see that is consistent about the 5 things I'm going to talk about is that they already have validated these kind of approaches. It's not a kind of small sample proof of concept. There's usually clinical or there's outcomes involved usually. There's usually multiple sites or multiple trials or multiple systems that are validating these findings for. So the first thing that I wanted to highlight was a paper that came out earlier this year in the American Journal by Greg Simon's group out in Washington. The topic was risk scoring for future suicidal behavior. And what they did was that they used tons and tons of EHR data, something like 3 million patients and 9 million visits or something, to develop a passive algorithm that was based on just things that were already existing in the medical record. They didn't have to necessarily change physician behavior or introduce any new protocols. And they derived an algorithm on data from one large health system. They validated it on 1 million subjects, maybe from another large health system or whatever way they divided it up. And the output of the algorithm seemed to track reasonably well the future suicide attempts or future suicidal behaviors in the individuals that it was tested on. The top 5% of the scores, of these risk scores, people who fall in the top 5% of those risk scores represented over 40% of the people who did eventually have an outcome, suggesting that just using passive data that was collected in an electronic medical record can give us some signals about future suicidal behavior, and that there's a clear opportunity there for screening or risk scoring. And again, I don't consider this a proof of concept. If anything, I think that I think it's a great paper, but it definitely isn't. We're no longer in the behavioral forecasting in the context of suicide screening and prediction. I think is no longer a proof of concept issue. The second thing that I mentioned was that, when people think about going into treatment, there are a lot of barriers that they face. They face things like stigma. They don't know where to get treatment. They don't know how they're going to pay for it. They don't know what copays or deductibles are. The whole process is very confusing. We did one study that we published in Psych Services. I think it came out this year, trying to predict who is going to drop out of treatment at some point post-diagnosis. And secondly, if they are going to drop out, why will they drop out? We used, again, something like 20,000 subjects worth of data, created a very short self-report questionnaire that just uses things that you could definitely ask in a waiting room, or the patient could for sure self-report while they were waiting. And combining that information with things like machine learning gives you outputs that are about 2 to 3 times better at predicting treatment dropout than random guessing or than just guessing the average. And more specifically, it seemed like we were able to develop specific risk assessments that would predict specific reasons why someone might drop out. And so the goal of that kind of work is that when someone comes in, they could maybe fill out this assessment in a waiting room, and then you could give the case manager the top 3 most likely reasons why someone would drop out, and perhaps a risk score as well that would correlate with the likelihood of them dropping out. So the case manager would then at least have an opportunity before that person leaves to be able to engage them on topics that might be going on in their head, given things like socioeconomic risk, given things like their age, their gender, their race, and perhaps some of the specific symptoms that they're experiencing. The third paper that I wanted to highlight is this issue of antidepressant treatment selection. It gets a really bad rep, this issue of trial and error treatment, particularly with antidepressants. One thing that we wanted to do, this was back in 2016 now, was to just say for a single antidepressant, for something like citalopram, can we predict whether or not this person's going to recover, just at a very, very broad level. We showed that we could develop a very short assessment, again, of the same kind that I just described, that could for sure be done in a waiting room. It can make predictions about the likelihood of response, and then we validated that across a couple of large trials. And it turns out that when people take the treatment that is in line with the prediction, they're about 2 times more likely to recover. Again, suggesting that there are very simple things that we can do while people are in waiting rooms before they go into treatment that might help us understand the likely outcomes and perhaps change our decisions before they have a chance to experience those negative outcomes. Finally, this is a really wonderful study that came out by Jamie Delgadillo's group in the UK. This is the IAPT program, which many of you are probably familiar with. This is the National Health Services in the United Kingdom has a large countrywide system for implementing psychological treatments. And so they do a bunch of frameworks that help us, navigate certain people through this system. So everyone starts in and they get a risk assessment, and if they have high severity, then they'll go into a kind of a high intensity workflow. If they have, a less severe condition, they'll go into a low intensity workflow that includes things like digital tools. So the goal of this study was that they developed a framework for monitoring. In the US, it's called measurement-based care. In the UK, sometimes it's called feedback-informed treatment. But the goal is to measure people's progress while they're just going through treatment. You don't actually change the treatment necessarily, but you just collect that data and then provide it back to the clinician and just let the clinician know how someone is progressing. This was a phenomenal study. It was validated across 8 different states. They're called trusts in the UK. And the goal of them was to identify outpatient non-responders. So if someone's going to recover anyway, there's kind of limited, there's not much you can do. Either if they're on track, keep doing what you're doing. But for people who are not on track, there is an opportunity to change what you're doing and to maybe think through ways that we could do something differently to help that person get back on track. They did that. They developed this system for collecting outcomes routinely through phones or when they come in through case managers. And they showed that in the intervention arm where they were doing all of this and they were showing the clinicians those outcomes, they actually found 8%, this is an absolute risk difference, 8% higher recovery rates for those who go off track. 8% sounds like a small number, but I'm pretty sure that venlafaxine versus placebo had approximately the same absolute risk reduction. And so maybe just collecting outcomes and showing it to the physician is another $1 billion a year intervention. Last example is really this issue of relapse. I'm just going to touch briefly on this, but there is growing interest in this issue of forecasting relapse or anticipating people who might relapse or better understanding the trajectory or the process that's involved in relapse. This was some work done at Yale by Relitsa Gegeva's group. She's a biostatistician there. And what they did was they aggregated a number of clinical trials and then concatenate all of the outcome data from that and fitted growth trajectory models and then tried to predict class membership into these different trajectories. The goal was that you can come up with, again, specific risk factors that help you understand the likely trajectory that a person might have when they either do or do not discontinue antidepressants following a successful treatment. The last thing I'm going to say is that we can also think about how we're going to deliver these things and what is the fastest opportunity for progress. I think that's something that's really awesome that I love about Srijan's work is that it's a delivery model and it's an opportunity that no one really was taking advantage of. No one was going and running studies on a bunch of residency programs, and it's pretty clear now that there was a ton of opportunity there because they've collected tens of thousands of patients worth of data. I think I just wanted to kind of flag one thing that we've been doing is getting similar amounts of traction through employers. So employers are a kind of unique opportunity in the United States because large employers particularly actually pay the healthcare bills in the background. So when they provide you insurance, say you have an Aetna plan or you have a United plan, your employer is probably, most likely if you have more than 1,000 people who work for that company, your employer is actually paying all of those bills in the background. Aetna was just administering it. And what that means is that employers are directly financially incentivized to do something about cost of care. Because if you can reduce total cost of care, then they actually receive those savings. And the second is that if you can improve the clinical outcomes, they're also directly incentivized. Mental health care, or the cost of mental illness is particularly pronounced in terms of things like productivity and absenteeism. So employers in the United States are a kind of unique opportunity where we might be able to get faster progress. And so something that we've been doing with a few of these employers, ranging from relatively small tech companies like MongoDB with maybe 1,000 employees, all the way up to Gap and Whole Foods who have 100, 150,000 employees in the US. And developing frameworks that allow us to deliver treatment, quicker, faster, and cheaper, or quicker, better, and cheaper, I should say. So we start by doing engagement campaigns, sending out information, letting them know about the benefits of mental health care and different ways that they can access that. Giving them web platforms or iOS apps or whatever that may be to figure out what conditions they might be experiencing. So screening them for things like depression, things like anxiety, but also eating disorders, suicide risk, postpartum depression, whatever that may be. Presenting them different treatment options and where possible, maybe using the scientific literature to help inform those decisions, whether that's from clinical guidelines, whether that's from specific well-validated research studies, and then providing those insights to the providers, and then in an ongoing fashion, delivering measurement-based care and helping get non-recoverers back on track and help overall increase the number of people that recover. 3 points really just to take home. One, I think we can use new technology, particularly new statistical techniques in many cases, to help address problems across the whole of mental health care. I think there are lots and lots of instances where we can improve things, so the field is wide open. And I think that there is also great evidence that you've seen today in the last couple of days. We can already do this in the real world with real patients, and I think that psychiatry is sometimes a little bit overly critical of how far we have come. Thanks.